Welcome, CyberMDs, to another cardiology lecture for the USMLE Step 1 exam. Today's lecture will cover the effects that may be seen following cardiac insult from myocardial infarction. Before we get started, please remember to like, comment, and/or subscribe if you find the content here useful in any way so that we can continue to provide free medical education resources for students around the world. Additionally, please tell your friends about our content and let us know if you think that we can improve the lectures in any way at all. For this lecture, we'll discuss the various macroscopic and microscopic changes as well as the clinical complications that may arise. I want you to pay close attention to the title and the structure of this lecture. This is about temporal complications. So when these complications, whether macro or micro, occur in time relative to the myocardial infarction. That's how this lecture is structured, that's how this lecture is organized, and that's how you should think about this material. Simply knowing the timeline can help you rule in or out certain pathologies, both on the exam and in real life. Now, let's dive into the lecture. In the initial hours following an infarct, gross changes are often not visible. The affected myocardial region typically appears unaltered, although in some cases the area may be darkened due to cyanosis as a result of decreased oxygen supply. At the cellular level, the ischemic injury triggers a series of changes. Some of the changes may include hypereosinophilic changes of the cellular sarcoplasms, which creates a quote-unquote waviness at the edge of the infarction. Electron microscopy may show relaxation of the myofibrils, loss of glycogen, or swelling of mitochondria, as well as sarcolemma destruction. There may be mitochondrial amorphous densities towards the end of this time frame. A lot of these are difficult to really see, and so a lot of times they aren't tested on step 1, but they're still worth mentioning. As far as clinical complications during this time frame go, acute clinical complications may include arrhythmias as well as hemodynamic instability in the form of cardiogenic shock if the infarct is large enough. Another complication can be acute heart failure. In the next time frame, which is about 4 to 24 hours, the ischemic region of the infarction can start to appear dark and mottled compared to the surrounding tissue that is still being perfused. And that's going to be due to the coagulative necrosis that is occurring. The center of the area often develops a yellow discoloration in the later portion of this time frame, so closer to the 24-hour mark. Histological examination at this stage often begins to reveal, again, coagulative necrosis with loss of the nuclei within the cells. The influx of neutrophils often begins at the very end of this period. So again, at the end of 24 hours, the start of the first day, or end of the first day rather, and that's marking a defined inflammatory response in the tissue. So we know if we see neutrophils that we have an inflammatory response. And as far as clinical complications go, the risk of arrhythmias continues during this period and will be the most likely complication at this point. Now, between 1 and 3 days, the infarcted area will continue to appear pale and yellowish on a macro scale and become soft due to the progressing necrosis, inflammation, and the starting of fibrotic processes. The area of infarction microscopically is characterized by the infiltration of both neutrophils and macrophages, as that inflammatory response has progressed and there is a need for phagocytosis and promotion of healing and fibrosis. Be sure to link these microscopic changes in this lecture to the inflammatory response system of the body as a whole and know the tissue factors and cellular interactions present. The clinical picture may be complicated at this point by arrhythmias still, as well as a fibrinous pericarditis. The fibrinous pericarditis at this time makes sense and is concordant with the macroscopic findings of fibrosis. So if your patient has a friction rub upon auscultation of the heart, or a chest pain that is relieved as they lean forward and may be worse with lying down or with deep inspiration, aka pleuritic chest pain, these could be signs of a fibrinous pericarditis, assuming that the time frame is appropriate. Remember, these are temporal complications. This will often be compared or contrasted to Dressler's syndrome, which we will discuss shortly. During days 4 to 7, not too much changes with regards to the macroscopic view of the heart. The infarcted area continues to appear pale and yellowish, and it'll continue to soften due to the further progression of necrosis, inflammation, and early fibrosis. With regards to the microscopic changes, this period is predominantly characterized by the removal of dead cells and debris, which means it's going to be predominated by macrophages. With regards to clinical complications, there's significant changes in what our patients are at risk for during this time frame. There's an increased risk of ventricular free wall rupture, which is a rupture or tear in the free wall of the left ventricle, and remember that's the main pumping chamber of the heart. The rupture can result in the sudden escape of blood from the left ventricle into the pericardial space, leading to cardiac tamponade, which is a condition where the accumulating blood compresses the heart and impairs its ability to pump effectively. Cardiac tamponade can cause a rapid decrease in blood pressure, can lead to shock, and is potentially fatal if it's not promptly treated. The clinical presentation of ventricular free wall rupture may include symptoms such as severe chest pain, shortness of breath, a rapid and weak or quote-unquote thready pulse, low blood pressures, and other signs of shock. Another complication is rupture of the ventricular septum, and that's essentially a ventricular septal defect being formed due to the bursting of or the rupturing of the ventricular septum. And this is going to cause a left to right shunt in our patient's heart. The sudden shunting of blood between the ventricles can lead to volume overload on the heart and compromise its ability to pump effectively. This can result in symptoms such as shortness of breath, fatigue, and fluid accumulation in the lungs. This makes sense intuitively. You have a high-pressure system on the left side of the heart that is now able to add volume to the right side of the heart, which is usually a lower pressure system, and the right side of the heart can then add volume to the pulmonary circuit, which then adds more volume than normal back to the left side of the heart, and none of these areas of the cardiovascular system are used to that type of volume. So you get a lot of heart failure-esque signs and symptoms. Finally, during this time period, 4 to 7 days, patients may also suffer from a rupture of a papillary muscle. And that's often on the left side of the heart, which means it's going to result in mitral valve insufficiency and regurgitation. Remember that when a papillary muscle ruptures, it impairs the normal functioning of the affected heart valve. The rupture causes a disruption in the support and tension provided by the papillary muscles and the chordae tendineae, leading to valve regurgitation. This means that blood can flow back into the left atrium instead of being efficiently pumped out into the systemic circulation. Severe mitral regurgitation can lead to symptoms such as shortness of breath, fatigue, and fluid retention. On your exams and in real life, you will often have to use your physical exam findings, such as the sound of the murmurs in the ventricular septum rupture and papillary muscle rupture, causing mitral regurgitation, or distant heart sounds in tamponade due to free wall rupture, to distinguish which of these complications is occurring. Alright, our patients made it 1 week out, so now we're talking weeks 1 to weeks 3. At this point, the edge of the infarcted area begins to develop something known as a quote-unquote red border. This is due to the granulation tissue that is beginning to form in these areas. The granulation tissue begins and completes maturation during this time, as was just mentioned. Additionally, though, there is increased collagen deposition and neovascularization at the cellular level that is taking place. And this stage marks the transition from inflammation to fibrosis. Many of the aforementioned complications may occur during this time frame, but here arrhythmia is going to be the most common. All right, next let's talk about our 1 to 2 month timeline. At this point, a dense collagenous scar is going to continue to replace that necrotic myocardium, leading to a thin gray-white area of scarring. The scar consists of dense collagen at the microscopic level, and it's going to lack cellularity, resulting in decreased contractility of the affected area. Clinical complications include, for one, mural thrombosis, which is the formation of a blood clot within the wall of a blood vessel. Specifically, in the context of a myocardial infarction, mural thrombosis refers to the development of a clot within the ventricular chamber of the heart, usually in the area affected by the infarction. The clot forms as a result of platelets adhering to the damaged endothelium and aggregating, creating a plug-like structure. Mural thrombosis poses several risks. The clot can grow in size over time, potentially leading to a complete blockage of blood flow, which would result in a cardiovascular event, such as another heart attack. Additionally, if the thrombus becomes dislodged, it can travel through the bloodstream. This is known as an embolism, and it can lodge in a smaller blood vessel, often those in the brain, causing an occlusion and subsequent tissue damage, i.e. a stroke. To manage mural thrombosis, anticoagulation is often prescribed to prevent the formation and or the growth of these blood clots. In some cases, surgical interventions may be necessary to remove the clot. Ventricular aneurysm is another complication during this time period. Ventricular aneurysm refers to the abnormal outward bulging or dilation of a portion of the ventricular wall in the heart. It occurs as a consequence of weakened myocardial tissue resulting from the infarction. During the infarction, that infarcted area of cardiac muscle becomes damaged and dies due to reduced blood flow and oxygen supply. Then, over time, the weakened region may stretch and expand, forming an aneurysm. Ventricular aneurysms are most commonly found in the left ventricle, and the aneurysmal bulge can disrupt the normal contractility of the heart muscle, affecting its ability to pump blood efficiently. Additionally, blood flow within the aneurysmal sac can become sluggish, leading to the formation of blood clots, or thrombus, within the aneurysm itself. Some individuals may remain asymptomatic, while others may experience symptoms such as chest pain or shortness of breath, palpitations, or fatigue. Medical management may include medications to control the symptoms and to prevent complications. Another complication is known as Dressler syndrome. I mentioned this one earlier with regards to the fibrinous pericarditis and how the tests and examiners will compare and contrast these, and how knowing your timeline can help you to get those questions right. This syndrome is a rare autoimmune disorder that occurs several weeks after a myocardial infarction or a cardiac injury. It is characterized by inflammation of the pericardium, which again is the protective sac surrounding the heart. This is an autoimmune response triggered by the release of antigens from the damaged heart tissue. The immune system recognizes these antigens as foreign and mounts an immune response, leading to inflammation of the pericardium. Symptoms of Dressler syndrome may include chest pain that worsens with deep breathing or lying down. There can be fever, fatigue, or a dry cough. And these symptoms typically develop, again, weeks. We're in the 1 month to 2 month time period right now after the initial heart attack or cardiac injury. So this is like weeks on weeks after. The treatment for Dressler syndrome aims to just alleviate symptoms and to reduce that inflammation. This usually involves the use of an NSAID to relieve the pain and to reduce the inflammation. Persistent pericarditis could also lead to pericardial effusion and potentially cardiac tamponade if it wasn't properly treated. Finally, the remodeled myocardium, with its reduced contractility, may predispose patients to chronic heart failure and arrhythmias. All right, let's talk about anything greater than 2 months in time from the myocardial infarction. At this point, the scarring is complete and that dense collagen scar exists. Clinical complications continue to include mural thrombosis, ventricular aneurysm, and Dressler syndrome, as well as arrhythmia and heart failure. Let's recap. Myocardial infarction sets off a cascade of changes at both the macroscopic and microscopic levels, leading to a spectrum of clinical complications that occur over time and at specific time points. Understanding the temporal progression of these changes is crucial for the timely diagnosis and management of these MI complications. Thanks for tuning in, and please remember to like, comment, and/or subscribe so that we can continue to provide free medical education resources to students around the world. If you find our videos useful at all, please be sure to let a friend know, and remember that you can catch all of our lectures for free on Spotify. See you next time.